Hello. Classification.
Yes. The World Health Organization classifies pulmonary hypertension into 5 clinical groups based on pathophysiology, hemodynamic characteristics, clinical features, and management. Clinical classification. Group 1 includes idiopathic pulmonary arterial hypertension, heritable pulmonary arterial hypertension, drug and toxin induced PAH, PAH associated with connective tissue disorders, portal hypertension, HIV, congenital heart diseases, PAH with features of venous or capillary involvement, that is pulmonary veno-occlusive disorder, pulmonary capillary hemangiomatosis, and persistent PH of newborn. Group 2 includes pulmonary hypertension due to left heart disease, due to heart failure or valvular heart disease, congenital and acquired cardiovascular conditions leading to post-capillary pulmonary hypertension. Group 3 includes pulmonary hypertension due to lung diseases, hypoxia or both, obstructive lung diseases, restrictive lung diseases with mixed restrictive and obstructive patterns, hypoventilation syndromes, hypoxia without lung disease, and developmental lung disorders. Group 4 is due to pulmonary artery obstruction, that is chronic thromboembolic pulmonary hypertension and other pulmonary artery obstructions. Group 5 is with unclear or multifactorial mechanisms, including hematological disorders, systemic disorders, metabolic disorders, chronic renal failure with and without hemodialysis, fibrosing mediastinitis. The more common is the pulmonary hypertension associated with the left heart disease, and next comes the pulmonary hypertension that is associated with the lung disease. Hemodynamic classification. Besides the clinical distinctions, pulmonary hypertension has a hemodynamic classification scheme that can aid the diagnosis. A mean pulmonary artery pressure greater than 20 mmHg is above the upper normal limit. However, a mere mean pulmonary artery pressure elevation is insufficient to define pulmonary hypertension, as this elevation could be due to a cardiac output or pulmonary artery wedge pressure increase. There's a 6th World Symposium on Pulmonary Hypertension, and the European Society of Cardiology guidelines also classify pulmonary hypertension based on the pulmonary vascular resistance and pulmonary artery wedge pressures. These include 3 groups: the precapillary, postcapillary, and combined. Precapillary pulmonary hypertension is caused by an increase in the pressure in the pulmonary arterial system alone. It is characterized by a mean pulmonary artery wedge pressure of 15 mmHg or less. Idiopathic pulmonary arterial hypertension is an example of precapillary pulmonary hypertension. And post-capillary is caused by an increase in pressure in the pulmonary venous and pulmonary capillary systems. It is a result of elevated left-sided filling pressures in the left-sided heart diseases. And combined occurs when the pulmonary vascular resistance in 3 Woods unit or more. So in precapillary pulmonary hypertension, the mean pulmonary artery pressures are more than 20 mmHg, wedge pressures are less than or equal to 15 mmHg, and pulmonary vascular resistance is greater than or equal to 3 Wood units. It includes clinical groups 1, 3, 4, and 5. Isolated post-capillary pulmonary hypertension has mean pulmonary artery pressures more than 20 mmHg, wedge pressures more than 15 mmHg, and pulmonary vascular resistance is less than 3 Wood units, and it includes clinical groups 2 and 5. And combined has a mean pulmonary artery pressures of greater than 20 mmHg, wedge pressures more than 15 mmHg, and pulmonary vascular resistance greater than or equal to 3 Wood units. And it includes clinical groups 2 and 5. Etiology. Genetic mutations are associated with various pulmonary hypertension types, including idiopathic, heritable, and hereditary hemorrhagic telangiectasia associated with PAH. People with idiopathic pulmonary hypertension have a genetic predisposition, but the mutations are sporadic. These groups are clinically indistinguishable. The various mutations associated with idiopathic or hereditary pulmonary arterial hypertension are BMPR2, which is most common, SMAD1, SMAD9, and KCNK3, CAV1, and SOX17, while those associated with hereditary hemorrhagic telangiectasia are ALK1, ENG, and SMAD4 genes. Some drugs and toxins are known to cause PAH, which include aminorex, fenfluramine, dexfenfluramine, benflurex, methamphetamines, dasatinib, and toxic rhapside oil. Some substances that may give rise to PAH include cocaine, phenylpropanolamine, L-tryptophan, amphetamines, interferon alpha and beta, alkylating agents, bosutinib, direct-acting hepatitis C antivirals, and indirubin. Various connective tissue disorders are known to cause pulmonary arterial hypertension, including systemic sclerosis, systemic lupus erythematosus, rheumatoid arthritis, Raynaud's disease, and mixed connective tissue disease. Among these, systemic sclerosis is the most notorious for causing pulmonary arterial hypertension. Group 3 hypoventilation syndromes comprise conditions causing sleep disordered breathing. Hypoxia without hypoventilation is seen at high altitudes. And group 4 etiologies include chronic thromboembolic disease, sarcoma, other malignant tumors like renal cell carcinoma, uterine carcinoma, testicular germ cell tumors, and non-malignant tumors like leiomyoma, arteritis without connective tissue disorders, congenital pulmonary artery stenosis, and hydatidosis. These conditions can obstruct the pulmonary artery and cause pulmonary artery hypertension. Pulmonary hypertension associated with congenital heart disease is classified into congenital heart disease that causes Eisenmenger syndrome, PAH associated with prevalent systemic to pulmonary shunts, PAH with small or coincidental defects, and PAH after defect correction. While PH with congenital heart disease is predominantly classified under group 1, some defects are more appropriately classified under group 2, which include mitral valve disease, left ventricular inflow or outflow obstruction, and left ventricular systolic or diastolic dysfunction that may also result in post-capillary pulmonary hypertension. Chronic hemolytic anemia and myeloproliferative disorders are hematological disorders that cause group 5 pulmonary hypertension. Systemic diseases that can cause pulmonary hypertension include pulmonary Langerhans cell histiocytosis, neurofibromatosis type 1, and sarcoidosis. Glycogen storage disorders and Gaucher's disease are metabolic disorders that can cause pulmonary hypertension. Presenting complaints. The hallmark presenting symptom of pulmonary hypertension is shortness of breath on exertion. Non-specific symptoms may also be reported, including hemoptysis, fatigue, early exhaustion, palpitations, dizziness, and syncope. As the disease progresses, symptoms of right-sided heart failure manifest, such as weight gain, edema, abdominal distension, and ascites. Rarely, pulmonary artery enlargement may present with chest pain on exertion from left main coronary artery compression. Hoarseness may manifest from left recurrent laryngeal nerve compression, a condition known as Ortner syndrome. Bronchial compression may present as atelectasis, and pulmonary artery enlargement may also cause wheezing, cough, and frequent lower respiratory tract infections. Patients may also have symptoms related to their underlying diseases such as joint pain, skin rashes, cough, daytime somnolence, and a history of blood clots. Family, sexual, and travel history are highly relevant when evaluating a patient with suspected pulmonary hypertension. Decompensated patients may present with pulselessness, apnea, and unconsciousness, warranting immediate resuscitation. Patients with a prior history of pulmonary embolism, connective tissue disease or portal hypertension, HIV, or a family history of PAH are at-risk patients for PH, and warning signs such as syncope, tachycardia, hypotension, or signs of right heart failure, all of which suggest advanced PH, should prompt an expedited referral directly to a specialist PH center. Physical examination. An increased P2 component of the second heart sound is usually the initial finding. Jugular venous distension with a prominent A wave is seen with an eventual prominent V wave, signifying tricuspid regurgitation as the disease, and the right ventricular dysfunction ensues. Elevated pulmonary pressures and eventually right ventricular failure cause tricuspid and pulmonary regurgitation murmurs and S3 or S4. Ascites, abdominal distension, hepatomegaly with or without splenomegaly, and dependent edema may also be seen. Pallor, delayed capillary refill, and peripheral cyanosis may be seen as right ventricular failure progresses, signifying a low cardiac output state. Various other physical examination findings may be present in patients with connective tissue disorders or chronic lung diseases such as digital clubbing, Raynaud's phenomenon, digital ulceration, gastroesophageal reflex signs like abdominal tenderness, crackles or wheezing on lung auscultation, and joint swelling and erythema. A high index of clinical suspicion for PH is needed to ensure appropriate diagnosis and clinical management of patients. A new diagnostic algorithm, including a fast-track referral pathway, has been proposed by European Society of Cardiology to encourage earlier detection of PH in patients. The basic concepts in evaluation include 3 steps. The first step is the initial evaluation for suspecting PH, including clinical review, ECG, and blood test for brain natriuretic peptide. Step 2 involves the first-line investigations, with the investigation pathway diverging according to the suspicion of lung disease versus cardiac disease. And the final step suggests which patients to refer on to a PH center. These include patients with intermediate or high probability of PH and patients at risk of PH. Step 1 includes lab test, routine hematology studies, renal function tests, liver function tests, iron profiles, and thyroid studies should be performed in all patients with clinical signs of pulmonary hypertension. Thyroid dysfunction should always be suspected in individuals with abrupt deterioration, as it is common in PAH and may occur during the disease course. Routine HIV screening, hepatitis virus serologies, and connective tissue disorder tests should be performed. BNP and NT-proBNP levels are independent outcome predictors and may also be considered during evaluation. Patients with scleroderma have a high PAH prevalence and should be routinely screened with anti-nuclear antibody immunofluorescence. Patients with CTEPH and those with CTD associated with thrombophilic states should also be screened for coagulopathies and thrombophilias, including lupus anticoagulant, anti-cardiolipin antibodies, and anti-beta-2 glycoprotein antibodies. Patients may have abnormal LFT values due to congestive hepatopathy from either right heart failure, liver disease, or endothelin receptor antagonist therapy. In ECG, P pulmonale right axis deviation, right ventricular strain pattern, right ventricular hypertrophy, right bundle branch block, and QTC prolongation, which represent signs of right-sided heart strain and chamber enlargement, can be seen. Supraventricular tachycardias, including atrial flutter and fibrillation, can occur in advanced diseases, but ventricular arrhythmias are rare. However, a normal ECG does not exclude the diagnosis of pulmonary hypertension. Step 2, 2D echocardiography and Doppler. The transthoracic echocardiography remains the single most crucial non-invasive assessment tool for pulmonary hypertension. However, echocardiographic assessment should only be used to estimate the pulmonary hypertension probability. A tricuspid regurgitant jet velocity greater than 2.8 meters per second, which corresponds to a pulmonary artery systolic pressure of 35 mm Hg or greater, suggests pulmonary hypertension. Pulmonary artery systolic pressure, which is measured by echocardiography, is subject to inaccuracy in patients with suboptimal echo sting windows, that is large anterior to posterior chest diameter, observed commonly in obesity or obstructive lung diseases, and this does not provide key data such as pulmonary artery wedge pressure that indicate pulmonary venous hypertension, that is left-sided heart disease. Furthermore, 1/3 of the patients with a measurable tricuspid regurgitant jet have pH when assessed without a measurable tricuspid regurgitant jet have pH when assessed by cardiac catheterization. Therefore, it is helpful to consider tricuspid regurgitant jet velocity results in combination with echocardiographic parameters that increase the probability of pH, which includes right atrial dilatation, right ventricular, left ventricular basal diameter, flattening of the interventricular septum, and decreased RV systolic function. The decreased RV systolic function can be quantitated by analyzing RV strain or displacement of the tricuspid annulus, referred to as the tricuspid annular plane of systolic exertion, which is clinically useful tool for prognosticating adverse outcome when less than 1.7 centimeters. Increased left atrial volume greater than 0.34 ml per meter square, left ventricular hypertrophy, and early to late diastolic inflow velocity, which is 1 to 1.5, with decreased early diastolic mitral annulus velocity and less than 7 centimeters per second, and a ratio of early diastolic mitral inflow velocity to early diastolic mitral annulus velocity average greater than 14 are all suggestive of a left heart contribution to PH. The first image depicts a continuous wave Doppler imaging acquired from an apical 4-chamber view in a patient with advanced stage PAH demonstrating severe tricuspid regurgitation. In the inset, the velocity of the tricuspid regurgitant jet is 4.8 meters per second, which suggests mild pulmonary hypertension and corresponds to an estimated right ventricular systolic pressure of 98 mmHg and estimated pulmonary artery systolic pressures of 108 mmHg. In the second picture is a four-chamber view depicting severe right ventricular and right atrial dilatation. This is a short axis two-chamber view, and the first image depicts interventricular septum imaged at the end systole, which is flat, suggesting D sign, indicative of RV volume and pressure overload. And the second picture depicts measuring the TAPC, which quantitates the apical displacement of the tricuspid annulus between diastole and systole, measured by M-mode echocardiography. Right heart catheterization. The RHC confirms the diagnosis of pulmonary hypertension by giving enormous information, including right and left-sided filling pressures, pulmonary artery pressure, wedge pressures, pulmonary vascular resistance, and cardiac output. Vasoreactivity testing is an RHC component that should only be done in patients with idiopathic or heritable pulmonary arterial hypertension and drug-induced PAH. Inhaled nitric oxide at 10 to 20 parts per million is usually preferred, but intravenous epoprostenol, intravenous adenosine, or inhaled iloprost may also be used. The test is deemed positive if there is an mean pulmonary artery pressure decrease of at least 10 mmHg, resulting in a final mean pulmonary artery pressure of 40 mmHg or less, and either unchanged or increased cardiac output. Patients who test positive are suitable for high-dose calcium channel blocker treatments. A left heart catheterization should also be performed in individuals with clinical risk factors for coronary artery disease or echocardiographic signs of left heart systolic or diastolic dysfunction. The most feared complication of the procedure is pulmonary arterial rupture. The nuances regarding RHC measurements include external pressure transducers must be calibrated at 0 to 0 at the level of the left atrium, and the wedge pressure should be measured at the end of normal expiration. Cardiac output should be measured using triplicate thermodilution. However, the thermodilution may be inaccurate in patients with intracardiac shunts, warranting direct fixed estimation. This is the right heart catheterizing tracings of pulmonary artery pressures and wedge pressures. By inflating the blue tracing indicates the pulmonary artery wedge pressures. By inflating the balloon of Swan-Ganz catheter, the transition of the pulmonary artery pressure curve to the pulmonary artery wedge pressure curve may be observed. These are the tracings and a normal pulmonary hemodynamics. The pulmonary vascular resistance is calculated as mean artery pressures minus wedge pressures by cardiac output. And these are tracings in a patient with severe pulmonary hypertension.
You should have tweaked these images. We can hardly see it. Should have increased the brightness or contrast or whatever, when you are okay. Anyway.
Contraindications of right heart catheterization are recently implanted pacemaker less than 1 month, known right atrial or ventricular thrombus, mechanical right heart valve, tricuspid valve clip, and acute infection. Other investigations include chest X-ray. Chest radiography may reveal underlying pulmonary hypertension, such as right atrial enlargement, pulmonary artery enlargement, peripheral vessel pruning, and a water bottle-shaped cardiac silhouette. Signs of left heart disease like curly B lines, pleural effusions, and left heart enlargement may also be present. Patients with lung disease may have diaphragmatic flattening, hyperlucency, volume loss, or reticular opacifications on X-ray, depending on their condition. Pulmonary function tests. Most patients with pulmonary arterial hypertension have decreased carbon monoxide diffusion capacity. A DLCO of less than 45% is associated with poor outcomes. Arterial blood gas analysis. Patients with PAH usually have a low normal or slightly low partial pressures of oxygen. A severely reduced PO2 should raise suspicion of for shunting, as in a patient with patent foramen oval or hepatic disease. Patients with PAH may also have alveolar hyperventilation, often producing a low to normal PCO2s. CT chest is essential for identifying interstitial lung diseases, helping differentiate between various pulmonary hypertension groups. A pulmonary artery diameter of at least 30 mm, right ventricular outflow tract thickness of at least 6 mm, septal deviation greater than 140 degrees, or right to left ventricle ratio of at least 1 is highly predictive of pulmonary hypertension. The CT pulmonary angiography often has a high diagnostic accuracy for CTEPH, and it demonstrates CTEPH signs such as webs, bands, filling defects, enlarged bronchial arteries, and mosaic perfusion. The ventilation perfusion scan is performed to rule out CTEPH in patients with pulmonary hypertension. This diagnostic test remains the preferred modality since a normal scan can exclude CTEPH with a sensitivity of 90% to 100% and a specificity of 94% to 100%. And recent CT, MRI, and single photon emission CT advances have narrowed the gap between ventilation perfusion scan and these other modalities. This is an algorithm depicting the evaluation of pH. And in fast track referral, the warning signs are rapid progression of symptoms, severely reduced exercise capacity, pre-syncope or syncope on mild exertion, signs of right heart failure, and screening in at-risk patients. Approximately three-quarters of patients with connective tissue disease associated PAH have systemic sclerosis as the underlying disease, and the prevalence of PAH in patients with systemic sclerosis ranges from 7% to 19% and carries a poor prognosis, which can be improved with early detection and initiation of targeted PH therapy. The latest PH guidelines recommend annual systematic screening for PH in patients with systemic sclerosis, with the DETECT algorithm recommended for screening asymptomatic adults with systemic sclerosis of more than 3 years duration. Unlike patients with systemic sclerosis, screening asymptomatic patients with portal hypertension or HIV is not recommended given the lower prevalence of PH in these conditions. However, patients under consideration for liver transplantation or a transjugular portosystemic shunts should routinely undergo echocardiography screening for portopulmonary hypertension. Patients with dyspnea and a history of previous thromboembolic disease require further evaluation for chronic thromboembolic pulmonary disease or chronic thromboembolic pulmonary hypertension. Thank you, sir.
That's it.
Yes, sir.
So you're not talking about the treatment part of it. Okay. Now, I thought, when you talked about a classification, you went into a little bit of the history. The original pulmonary artery hypertension was classified by Heath and Edwards. And the importance of the Heath Edwards classification is they divided it into six stages, and the first two stages are vascular reactivity, medial hypertrophy, and then on the third Heath Edwards classification, stage three, the fibrosis sets in, and then further problems occur. So further progression occurs. Now the importance of this is up to stage 2 or early stage 3, the pulmonary arterial hypertension is reversible. If it is beyond stage 3, that means when fibrosis is already set in, pulmonary arterial hypertension is irreversible. So that is a significant thing in our practical management of pulmonary artery hypertension. Then, and in the same way, you should have also mentioned about the reversibility. You just touched upon it a little bit, but on in the CATS right heart CATS study, they give oxygen or nitrous oxide and see whether the pulmonary arterial hypertension comes down. This is very important when you are assessing a patient with a left to right shunt, then converts itself into right to left and just before Eisenmengerization. When it is already reached the Eisenmenger state, then whatever surgical procedure that you have to do will only deteriorate the patient much further than helping him. So these are important things that you have to know when you are assessing a patient with pulmonary hypertension, especially with cardiac causes. and see whether a surgical management is first is indicated or not, and second, is the patient going to be fit for that, and third, is the patient going to improve after your surgical management. So these are the three things that you have to assess.
Yes, sir.
Anything to add, sir?
No, same thing as you said, because most of the examiners ask you about the heat and the endurance classification. Stage one, where there's medial hypertrophy, stage two, where there's intimal hypertrophy and something. Stage one and two, completely reversible. Stage three, partially reversible. 4, 5, 6, not reversible. And the final sixth stage, necrotizing and the arthritis, fibrinoid and the necrotizing arthritis. These are new stages. And also the functional classification, like New York Heart Association, class 1, where patient has no symptoms, to class 4, where patient has a bedridden, cannot do anything, or even any exercise, increases the breathless. So these are the two things I have to point out. The Keith and Edward, because every examiner will ask you that thing. You have to know the 6 stages of each Edward and also functional classification of this. Okay.
Yes, sir.
Maybe with the newer classifications, WHO classifications, people don't follow Ethan Edward classification anymore. But for a surgical this thing, or for our own practical management of these patients, we should know which cases of pulmonary hypertension are reversible and which are not reversible. So this pathophysiological classification is still important, I feel, before, because all the other newer classification is basically made on etiological principles, and then the severity of the pulmonary arterial pressure, and so on. But the basic pathophysiology is not addressed in those newer classifications.
Yes, sir.
So I mean, you should have probably, maybe you should talk to one of the pulmonologists, or either Murli Mohan or Ranganath, and then see what are the latest things, and what are the things that are involved in clinical evaluation, which are the cases that require surgery, which are the cases that require medical management, and things like that. Okay,
Yes,
so
sir.
this thing has become a little incomplete. Maybe you will have to do the management part of it as a separate class, maybe.
Yes, sir.
Many years ago, I heard a talk by the great Christian Barnas in Mumbai about deciding the operability of a left to right shunt based on the lung biopsy. Nobody does it nowadays, because you have to make a clinical assessment and cardiac cath and the reversibility on oxygen or nitric oxide. The pulmonary art, the lung biopsy is not done because one, it's a very difficult thing to decide whether it's stage 3 or 4. So, and also very often you take a biopsy from the apex of the lingula. That is easiest, You can just clamp and cut the. So that thing is never done nowadays to decide whether a left to right shunt is still operable or not. You have to go by the clinical, by the cardiac cath and the use of 100% oxygen and nitric oxide, whether the shunt increases, the left to right shunt increases, or if the cyanosis completely disappears, the right disappears and it becomes a high left to right shunt. So that is the importance of the ETH and Edwards classification. As Krishna said, it's not very relevant now to decide whether the PH, pulmonary arterial hypertension, is reversible on the.
Yes.
So just to reiterate what I've always been telling you all, so whenever you pick up a topic or pick up a condition, you should know what it is, that is the definition, why it occurs, and why you should treat, when to treat, how to treat, and when not to treat. These are questions that you have to know as basic principles for any condition. If you know the basic principles, then you will be able to assess the patient better and choose the right patient for the right procedure. So it's very important to learn to analyze a patient in this manner, so that you don't do unnecessary operations and get into trouble, and you also know when to do which is the best time to do, and subsequently when not. That is most important, whether you are going to do good for the patient or not. That is most important ultimately.
Yes.
So just because you can do a procedure doesn't mean you should do. So that should be the foremost in your thinking process.
Yes, sir.
Okay. Any other questions? Anybody has any other doubts?